I'm going to speak very briefly and just give you an update on COVID in Ohio and the health system. And then we'll have a TED Talk, and we're going to leave a lot of time for questions. What we'd like to do is, if you have any questions, go to your chat or your question and answer box, and feel free to send them along to me, and I will pass them along to Ted and Brett this evening. So I think many of you are probably used to some of my weekly WebExes related to COVID and the UH system on a whole. And I always start with how am I feeling about things and what's the color, so to speak. And so today is a day of cautious optimism with, however, a strong flashing yellow light. And why is it that I say that? Well, we've been following cases with a 21-day average across the state. And today, it's a little surprising for me to report that both total cases, deaths, hospitalizations, and ICU admissions today are up compared to the 21-day average this week. So to give you an example, cases are up 731 in the last 24 hours compared to 578 daily average. Deaths 55 compared to an average of 41. Hospitalizations 97 compared to an average of 84, and ICU admissions 28 over an average of only 17. And if you look what's happening at university hospitals itself, we are at near a high of our total admissions within the health system, with over 91 patients across all of our hospitals, both Cleveland Medical Center and the community hospitals, with 39 patients in the intensive care unit. So what's the cause of this increased number of cases? Well, it's really twofold. One is an increase of cases in congregant living, such as nursing homes, assisted living, and prisons and juvenile detention centers. And we know that those have been a risk across the state. But what we're actually seeing in Northeast Ohio are some pockets of community spread with a big little surge, I guess you would say a micro surge, around University Hospitals Cleveland Medical Center in Fairfax, Glenview, Huff, and East Cleveland, and in that area. And that we know, based on what we're seeing in the emergency room and what's happening in terms of our admissions to CMC, is a little local spread. Now, the one thing I want to emphasize, and of course I'll leave it to Ted and Brett to get into the details, is that the Seidman Cancer Center, however, is a COVID-free zone in the hospital. So our inpatients are located on one unit in the Lakeside building, and our intensive care unit is in the Mather building. So we've intentionally isolated the patients to create very safe zones of patient care for all the other patients in the hospital. As you know, we've gone from preparedness and response to now also recovery. And on May 1st, with the governor's lifting of the elective procedure limit, we now are doing routine care, screenings, vaccinations, and any surgery and procedures that does not require an overnight stay. Of course, all essential surgery that's non-elective, meaning things that are either life-threatening, limb-threatening, or, as we'll talk about, affect cancer or cancer upstaging, or now are causing significant progression of disease that affect the quality of life, is still permitted. But with that, we've seen a marked improvement in return of patients across the health system, which has two very, very important implications. One, and most importantly, and we'll talk about a little bit later, is the fact that a lot of patients deferred needed health care during this time of the pandemic. Patients with diabetes, heart disease, lung disease, even patients with stroke and heart attack deferred care, not going to the emergency room or presenting very late into their course of treatment, which is not good. We had a big report out of the state of Michigan that childhood vaccinations have fallen to a dangerously low level of anywhere as low as 20% to only 40% of young children keeping their vaccination schedules, which opens us up, for example, to outbreaks of measles and other infectious diseases. So it's very important during this recovery phase that we really think about, you communicate with your doctor. This is a doctor-patient relationship time open communication. If you need anything, make an appointment. And I can tell you in my own interventional cardiology practice, I've seen 7 patients in the last couple of days. People have called and said, hey, listen, Dan, I just can't hold off anymore. I'm not doing well. Will you see me? And of course, we'll do everything we can. We try to communicate by phone, but it's often not the same thing when you have a condition that requires a face-to-face interaction. So with that, I'd like to say, Ohio itself has done very, very well with the great work of Governor DeVine and Dr. Amy Acton. Our physical distancing is perhaps the best in the country, and we never had the surge like was seen in Michigan, in New York, New Jersey, or even my old hometown of Chicago, where shortages of ICU beds and ventilators was seen. That was not seen in the state of Ohio. Our maximum occupancy was in the mid-50s. So we prepared to increase our bed count from 1,700 to 5,100. Our ICU beds alone on the main campus from 120 to 360, and it was not needed. And we're very lucky for that and for our community. But we have really special guests tonight who you know very well, who are going to talk to us about really a very serious problem, and that is the management of cancer, the diagnosis of cancer during the COVID pandemic. And that creates very unique challenges. And what I'd like to do is call on Ted first to give us a little bit of a broad overview of what's at stake with cancer in the COVID era. And then we'll turn over to Brett for some real strong actions on the floors of cancer treatment. So Ted, it's all yours.
Thank you, Dan. And I want to acknowledge Dan's tremendous leadership as president of Cleveland Medical Center. He's been an incredibly steadying force and a great leader during this challenging time. So we all owe Dan a great debt of gratitude. Cancer in the COVID era is really a huge challenge. As we look to China and to other countries and how this pandemic was affecting those patients, what became clear was that cancer patients were a particularly vulnerable population. When you looked at the 11 million people in the Wuhan province in particular, there was a much higher rate of COVID infection in cancer patients than there were in the general population. Approximately 1% of patients, cancer patients, ended up being COVID positive, whereas the general population rate was about 0.25%. So cancer patients, unfortunately, were more susceptible to the disease. And in particular, lung cancer patients were those who fell victim to these infections at a much higher rate. In addition, because of all the treatments that cancer patients have to undergo, being chemotherapy and radiation therapy, the effects of the COVID virus were particularly more intense in that patient population. So when you looked at individuals who were suffering from cancer and developed COVID infection, there was as high as a 40% rate of ICU stays and or death in those patient populations. So we saw that as a clarion call here at Seidman Cancer Center to really protect our cancer patients from this pandemic well before other institutions around the nation recognize this. And as you'll hear from Dr. Glotzbecker in a few minutes, we really were leaders nationally in really beginning to mitigate and reduce the risk to our patients at a much earlier stage. I think it's also important to note that at no point during this time did our cancer patients have their care interrupted once it had already begun. So I think it's important to realize that the first thing we did was look at all of the patients who were newly diagnosed at Seidman Cancer Center and determine by a priority which patients absolutely needed to continue with their care because it was an urgent or an emergent cancer treatment that needed to continue. There were a minority of patients, however, who were newly diagnosed whose cancer treatment could wait a period of 6 to 8 weeks. So collectively, our entire team sat down with the different disease team leaders and actually categorize patients as urgent and emergent cancer cases versus those that could wait a period of time. And very thoughtfully, we continued treatment for patients who were in that urgent and emergent category. And frankly, the vast majority of our patients fell into that category because, as we know, cancer cannot wait. There were some patients, though, who were newly diagnosed whose treatments could be delayed a brief period of time. And those patients were kept out of Seidman Cancer Center and put on a list so that their treatments could be reinstituted when it was safe. And I'm happy to report that, as Dan said, because our curve has flattened in Ohio, every patient who was diagnosed during this period of time has either been scheduled or has begun their therapy. So the most important message I want to send to our donor community is that at no point did we interrupt cancer care for our patients to any significant degree, and certainly not to the point where it would affect their ability to survive their cancers or even have the best outcomes. The other initiatives that we undertook is a vast array of protections for our healthcare workers. So visitor policies are part of that, and Dr. Glotzbecker will go into that in greater detail. But it was actually a heroic effort to set up a lot of social distancing and physical barriers to protect patients as well as our caregivers. And then finally, we set up very specific guidelines for our workers to be screened every day so that they were not coming into work ill, even if they didn't know. And those who were in high-risk areas, we set up a special temp track capability, which allowed us to monitor our employees' temperatures on an ongoing basis. And if any of them were to develop a temperature, would automatically alert their supervisors so that they could be pulled off of the front lines of care. The other thing that I want to reassure our community is that clinical trials are really the foundation of cutting-edge cancer care, and they really allow us to deliver tomorrow's cancer treatments to patients today. Many of our partners and many of our colleagues in the cancer community around the nation actually suspended their clinical trial activity during the COVID pandemic. But through the strong work of Dr. Paulo Kamey, who heads our clinical trials unit, and Dr. Josephine Chan, we're able to continue our clinical trial activities. And in fact, expand some of them to include COVID activities at Seidman Cancer Center. A perfect example is Dr. Afshin Dalauti. It was studying a drug from a particular pharmaceutical company, which was also found to inactivate viruses. And in fact, was found to be, at least in the laboratory, active against COVID and inactivating the proliferation of COVID. So we actually expanded that study to be able to include cancer patients who had coronavirus as well. So research continued and in fact accelerated in a dramatic way during this challenging time. The final thing is, talent is really what separates outstanding cancer centers from one another. And while it's certainly difficult during this time to continue to recruit and bring great talent into the institution, we have dramatically upped our game, if you will, and brought in a lot of talented individuals, even during this difficult time. Over the course of the last 4 months, we've hired 20 additional physicians. And most importantly, we've recruited a new chief of solid tumor oncology, Dr. Jorge Garcia, who joined us just as the pandemic was starting from the Cleveland Clinic to head up our solid tumor oncology program. And another individual, Dr. Jorge Montero, will be beginning next week to head up our breast program. And he brings great talent to our institution as well. So I think to our donor community, the incredible generosity you've provided to us has allowed us to continue our research efforts even during these challenging times. And I think From my perspective, the greatest recruit that I've been able to bring to university hospitals is Dr. Glotzbecker, who's on the screen next to me here. And I think Brett and Melissa Hunt, our new Associate Chief Nursing Officer, have really just done a remarkable job of keeping our patients safe and instituting a lot of really heroic efforts that I'd like for her to comment on. And what I can say is Brett's been with us now 8 months, and it's been a real pleasure having her on the team.
So Brett, we have a lot of questions pouring in here. My question and answer thing is flying, and maybe we could start with one. What changes have you made in the environment at Seidman to ensure patient and staff safety?
Yeah, thanks for that question. I would say one of our initial decisions very early on, which I think you both alluded to, even before COVID was declared a pandemic, was changing our visitor policy. And I think that's probably one of the toughest decisions we made. And it was to very early on limit the visitors to having no visitors or caregivers or partners or friends come with patients to their visits, to their appointments for procedures, or when they're admitted to the hospital. And I think from the very beginning, all we could think about was how to then help the patients get through this journey without having their loved ones or friends by their side. And so from the very first day, we then worked with IT, nurses, students, everyone to get together and say, how can we still keep the patient and their caregiver, loved one, and friends still together during this? So we did a lot of work early on with iPad use, phone use, FaceTime. We quickly went into telehealth visits. I think the main thing is even when we couldn't have the loved ones around, the nurses would try to take that role on and be there for the patients. And if there was good news, bad news, any change in plan, the nurses would be by the patient's side, holding their hand, listening, and then making sure that the family member or loved one who couldn't be there heard the information. And I still think to this day, that decision of limiting visitors, in addition to some of the other things that we'll talk about that we put in place, has done an amazing job to help protect our patients and decrease their risk. And to this point, for all of our centers, through all of these 8 to 9 weeks, we've only had 3 to 4 patients with cancer be COVID positive. And that's a huge, huge number of patients that we are still able to treat safely and continue to keep from risk exposure to COVID.
That's a really good point. And one of the things that we've heard about, and perhaps, Brett, you could comment, and then Ted, is, we hear about reports that the rate of cancer diagnosis has decreased in recent months, somewhat similar to what we've seen with a 30 to 40% reduction in stroke and heart attack. But we know that that's really not the case, that these are continuing to happen. So what do you think is causing this effect? Is it lack of screening colonoscopy and mammograms? Is it people not going to the doctor? What do you think is causing it, and what do you think we can do about it?
Go ahead, Brett.
So I do think part of it is what we greatly decreased all of our screening studies. That was one of the first things when Ohio decided that we couldn't have elective procedures. And I think at one point, I think both Dan and Ted, the numbers, there were 14,000 screening mammograms that had to be rescheduled, in addition to all of the CAT scans for lung cancer and all of the colonoscopies. So I definitely think in terms of the actual diagnosis, that was one of the things that early on we stopped doing. I think the good thing is that very quickly, as soon as we said that we were starting to open, we've been able to ramp up. And Donna Plecha and radiology has done an amazing job getting those patients rescheduled. And then in terms of treatment, all of our patients, I think we were talking about volumes. Inpatient was 92%, outpatient down at main campus was well over 88 to 90%, and all of our community sites are still into the low 90s. So I think that volume that we weren't seeing then, quickly trust that we're a safe place to come and are coming back very rapidly.
I mean, that's really terrific news, and congratulations to you and your team, because as we know, we had specialties that were down at 20 to 30% of their usual capacity during the peak of the pandemic and the stay-at-home order, especially those specialties that were very elective. Cancer is obviously a very different thing, and I would say Cleveland Medical Center as a whole is now probably at 80% of capacity, but it's driven predominantly, of course, by the amazing work at Seidman, and then, of course, in the Harrington Heart and Vascular Institute, because heart disease is not really elective. You know, when you're having a heart attack, you need to be treated right away. So I guess, you know, Ted, maybe you could comment on that. You know, what's your approach with patients who you call up? You know, I see it in my own practice. People are like, well, Dan, you know, I don't know if I should really come in, and we have to have a big conversation about everything that we're doing to make it safe. So, you know, what is it that you're doing, and how do you get people who do have cancer to come back?
Yeah, I think, you know, to the point that you made earlier, the incidence of cancer hasn't decreased. It's just the incidence of patients coming in to be evaluated. There's no doubt, as Brett mentioned, that mammography and screening, lung CT rates are playing a role. But I think there are patients who haven't seen their primary care doctor, who may have an ache or pain that they're putting off because of this concern, that really need to re-engage with the healthcare system in a meaningful way. So I think there is certainly the pent-up demand, if you will, and there is a fear. But what I can reassure, and what I do with my patients, is reassure them that Seidman Cancer Center in particular, as you had mentioned earlier, is a COVID-free zone. So we take great pains to make sure that all the patients who come in are screened. Every patient prior to beginning a therapy is being screened for coronavirus. Certainly all our cancer patients who are having surgery and are being admitted to the hospital are being screened. So we've been very fortunate to keep Seidman Cancer Center, you know, coronavirus free. In fact, we've even begun to house the solid organ transplant team, because those patients are in particular risk as well. So we've tried to congregate all of the patients who do not have coronavirus in Seidman Cancer Center. But to your other point, I've called patients, and they do express some concern about coming back. And I think it's incumbent upon us as physicians to reassure them that it is safe, you know, to come back to a Seidman Cancer Center. In fact, it's probably safer than any other portion of our healthcare system because of all the pains that have gone into keeping it in that COVID-free environment. And I also, though, think, Dan, that there's a lot of fear out there that that is misplaced. So I think as physicians, reassuring our patients and letting them know that everybody that they come in contact with at Seidman will be masked, and they will be taking precautions. The appropriate social distancing will be in place, and there really isn't any place that they could be safer if they should come in to see their physicians.
Great.
Oh,
well,
can
Brett,
I also want to,
Yeah.
I want to add one other thing just
Sure.
to what Brett said earlier. And, you know, really the nursing staff, I can't say enough about the nursing staff throughout our cancer hospital, both on the outpatient and the inpatient side. And you would think, as we limited visitors and patients were on their own during this incredibly difficult time in their lives, that it would be reflected negatively on our patient satisfaction scores. But it's actually the exact opposite. Our patients, we've received so many letters just outlining the incredible care that the nursing teams and the physicians have offered, really being surrogate family for these patients while they're in-house. And our patient satisfaction numbers have never been better than they are right now, because people are really getting just the most compassionate care that is imaginable.
That's terrific. So, Brett, there's an interesting question that came up, and that is that if you are a cancer patient and you happen to develop a COVID infection, will you be able to receive cancer care at all, or will it be delayed? How is Seidman handling the COVID patient who actually has cancer?
So if the patient is COVID positive, we have a couple of areas that we actually could treat them with. So when the patient comes back positive, we meet with the disease team leaders, the patient's doctor, and we discuss, is this patient's treatment urgent, or can it wait until a couple of weeks so they're not having symptoms, they're COVID negative? If they still need to be treated, we've actually put together, with your help, a COVID positive infusion center. So we have 3 chairs that are within Seidman, but set away from the rest of the infusion, the pavilion, and the other parts of the cancer center, where we can treat all of our COVID positive patients. But we've been lucky so far that only 1 patient has had to be treated in that area. But we have that set up. And then for our patients that have symptoms and don't want to be exposed to other patients in the emergency room or in urgent cares, we've also set up a completely separate COVID rule-out clinic. So any of our patients from anywhere in the community who have fevers, respiratory symptoms, any concern, are sent to our respiratory clinic in Bolwell.
Terrific. Well, we do have a question, and I can't wait on this one because it's from our very own Jane and Lee Seidman. And so when the Seidmans have a question, we got to answer their question. So first of all, welcome to Jane and Lee. We thank you for everything that you do every day. And we want you to know, Jane, that even though you're not coming in as much, Seidman's really clean right now. And the environment is just fabulous, and you'd be really, really happy. There are a lot of plexiglass screens that are keeping everybody distanced, but other than that, it's shiny and looks as great as the day it opened. So I want to assure you of that. So the question that Jane has, and maybe I'll give a crack at it, and then we can have Ted and Brett weigh in, has to deal with hydroxychloroquine, that really tough question about what's the role of hydroxychloroquine in COVID? Does it prevent COVID? Should you take it? So I think, it's pretty clear now, and I'll really cite the expertise of Bob Salata, who's our physician in chief for the health system, the medical director of the Royal Green Center for Travel Medicine and Global Health, who had been the chief of infectious disease for almost 20 years. And Bob's feeling on this is pretty clear, which is that it should only be taken in the context of a clinical trial, because the data to date is very, very sketchy, that it's beneficial. And there's a lot of reports now, as many of you know, of what we call arrhythmias as a consequence of hydroxychloroquine due to something called QT prolongation. And the combination of hydroxychloroquine with azithromycin can be particularly dangerous. And in fact, there was a trial in New York that was stopped early because there was increased death in the hydroxychloroquine group compared to the group that did not receive it. So yes, there is some data that hydroxychloroquine has activity in vitro with coronavirus, but the data is very, very thin. And we would say that right now in patients who have very, very mild disease, there is an outpatient trial that we're a part of, and that would be the only recommendation that we would make around hydroxychloroquine at this time. I should also mention that it is now restricted heavily by the State Pharmaceutical Board that patients must have diagnoses like lupus and other autoimmune diseases that require immunosuppression to even get hydroxychloroquine, and that physicians who prescribe it without those diagnoses are at risk for sanction by the state. So I don't know, Ted or Brett, any comments about hydroxychloroquine from your standpoint?
Yeah, I can add that, there was a lot of positive feelings about some of the early reports out of France, but that was a pretty small study. There was 36 patients in that study, and there was some efficacy. What, to Dan's good point though, that we here at university hospitals were looking into an outpatient trial that was being run through the actually the AIDS Research Center, and that trial was going to be for patients who were convalescing at home to try to shorten the the time for COVID clearance, and that has been very slow to clear through the IRB for the reasons that Dan has cited. So I can report that from our Seidman Cancer Center patients, none of them are participating in that trial currently. There have been a couple of patients in the community who were prescribed hydroxychloroquine, and one in particular had a reasonable response to it. but it's not a widespread, it's not being used widespread in our patient population.
Yeah, what I would say, to Jane and Lee and others who are listening, is that UH has been very fortunate to participate in some really important clinical trials for COVID. We have dozens of trials that are active. I think the most important one, of course, was that we were Site 001 in the US for a randomized remdesivir trial comparing 5 days versus 10 days of an IV infusion. We've treated almost 100 patients in those trials. And, sadly, we're out of drug. We have about 5 patients left in the moderate treatment arm, and then we'll have to use the emergency use authorization compassionate supply, which unfortunately for the state of Ohio, it was distributed based on your case volume is very low. So we have additional drug as part of the Gilead donation of 1.5 million doses, which would treat about 150,000 patients. We'll have about another 40 to 50 doses at Cleveland Medical Center. But we do have other drugs and other therapies. We enrolled 3 patients in the last 24 hours in our intensive care unit with convalescent plasma, which is, after all, something close to the benign hematologists and those of you in the cancer center, which is if you have a COVID infection, your white cells make antibodies. Those antibodies rise over 2 to 4 weeks. And after 28 days, we harvest the plasma from those patients, which contain these protective antibodies, and then give it to patients. And for patients with severe disease, severe pneumonia or heart damage complicating their COVID infection, can be treated with convalescent plasma. And as I said, we've treated 3 in the last 24 hours. We also have trials with very powerful immunotherapy drugs that you use in cancer. One is to dampen inflammation, which I know Brett has used heavily in her experience as a bone marrow transplant doctor, called tocilizumab, which is an antibody to IL-6. That really quiets down the inflammation that we're seeing in these patients that go on ventilators. The average time on a ventilator for a COVID patient is 14 days, which is nearly almost 4 times higher than the average ventilator time for someone with typical pneumonia. And so, we have things that we're using. We're the first site in the US for a very exciting stem cell trial from Athersys that uses mesenchymal stem cells, again, to dampen the inflammation and promote the healing of the lung. And we enrolled the first patient in the United States and have now enrolled over 4 patients in the stem cell trial. So I think we have therapies, Jane and Lee and others who are listening, that are either have more data for effectiveness or are now being tested in clinical trials in very rigorous ways to see if they're beneficial. So I think I have another. Yeah, go ahead, Ted.
If I could add to that, I think, this shows a perfect example of where our immunotherapy efforts in cancer and where COVID cross. Because, those trials that Dan was discussing, the Athersys trial, as well as the other cell therapy trials, really are using the same facility that we use to generate CAR T cells. So that is a perfect intersection and shows how the investment that was made in that facility through the donor community is not only benefiting cancer patients, but it's certainly giving us a new weapon, if you will, against coronavirus. So it's a great example of how research in cancer is being used to help in this fight through immunotherapy.
So I have a question for Brett. I'm going to give you this one from Larry Kennedy, our good friend Larry out there. Hope you're doing well. And that question relates to the new CDC guidelines about the need to, or I guess you would say the permission from the CDC to back off on how obsessive we've become over wiping down our groceries when we go to Heinen's and come back. In other words, I guess the concept that it's really aerosolized droplets. It's not so much, that we're breathing in, not so much that live a long time on a surface. What's your feeling about that? Have you changed your practice at home? How are you handling those types of things?
So I haven't been wiping down my groceries as much. I mask all the time. My poor 5-year-old children wear masks when they go outside to walk down the street. We are very vigilant about social distancing and masking. And I will say, to the point where I was telling Ted the story, if my daughters run down to the bottom of my yard and get anywhere near people walking, the other one yells, "No, no, no, you're gonna get sick, come back." And so we are very social distancing, masking, no matter where we go, and we limit going to grocery stores or anywhere else. But I have wonderful masks by one of our nurses that were made for my girls that they wear everywhere.
Yeah. What about you, Ted?
It is encouraging that the CDC has shown, that it's more difficult, to pick up coronavirus from surfaces, but it's new. I think it's just that data has just come out. So I think continuing to be as vigilant as we can with the wiping down surfaces is still, the better part of valor at this point.
Yeah, I think one of the things that's worth mentioning, because we have, as many of you know, uhhospitals.org/restart is our UH Healthy Restart Playbook. And our tagline is screen clean and 6 feet in between. And that's gotten a lot of, we're helping businesses and nonprofit organizations, schools. I spend 1 to 2 hours a day on teleconference calls trying to get things reopened across Northeast Ohio. And I think one of the things we can't forget about, because we're focusing on engineering controls and plexiglass and HEPA filters, is good old hand hygiene. Nothing beats washing your hands all the time in 20 seconds with soap and water. If you've seen some of the demonstrations of culturing things off your hands, is better than Purell. So if you don't have soap and water, that's second best. But I would say the one thing that's really important if you do go to the grocery store, and I do go to the grocery store because I like to get out, I do wear a mask. And I do wash my hands, before I leave. I get back in the car, I have wipes, I wash my hands. I get home, I wash my hands. And we still are wiping down the groceries. So I agree with you, Ted. We're going slowly on giving up on that. So Larry, that's our answer for now.
My girls taught me that singing the ABC song is the 20 seconds you need for washing your hands. So you have to sing the entire ABC song.
Oh, that's a good one. I like that one.
Yeah.
That's a good one. So, I think one of the other questions I think, Ted, that's come up and is a frequent one, and you mentioned a little bit about it. I think when you said you screen for patients who have COVID, I think you meant a little bit about actually testing, which gets us into the viral testing and the antibody testing. So maybe, Brett, you could clarify a little bit on when you say screen for COVID in your patients who are starting infusion or cancer. Does that mean viral testing, antibody testing? Which one is it, or is it both?
So we do both. So we do both. So we screen, as Ted mentioned, but I do think you meant the COVID testing. We screen, so all of our patients, before they come in, get called 2 days before by one of our nurses or nurse partners or assistants to see if they have symptoms. So before they come in, we screen for symptoms to make sure they're feeling well. And then if they don't, we would just change their visit to the COVID clinic. But also for new starts for chemotherapy, all admissions to the hospital, all stem cell transplant patients, they all get COVID viral testing. Typically, we try 48 to 72 hours prior to their visit for inpatient admission or the donor for stem cell transplant.
Good. I think that's really reassuring, and I think obviously is important not only for the patient, right, but also for the caregivers who we're concerned about as well.
And I think also, Dan, from the standpoint of therapy, we do know, and particularly in our preoperative patients who are asymptomatic and undergo surgery and then develop coronavirus infection, their rate of ICU and complications is exceptionally high. So we test every patient prior to general anesthesia. And the numbers better than I, but I think it's reassuring to the community that only 0.8% of patients that we're screening, and these are hundreds of patients that are undergoing surgery, have tested positive. So it's very, very few patients who are asymptomatic and are testing positive. Yeah,
I think that is really important. I'm glad you brought that up, Ted, because there is a a variable understanding out in the community of what is the rate of what we call asymptomatic spreaders, viral shedders, so to speak, who have no symptoms at all. And, it's reported at different percentages in different populations. But what I would say is here in Northeast Ohio, with very good physical distancing, people wearing masks the way that, Brett's family is doing, is that the rate of positivity of asymptomatic patients is under 1%. And I think that's really important. So that tells you that it's pretty uncommon. It's not zero. And I think, all of us are sitting in the background, basically worried about what happened in Seoul, South Korea, which is one gentleman went to bars on Friday and Saturday night. And this one gentleman who developed COVID ended up infecting 168 other individuals that evening. And South Korea has very elaborate, cell phone records and triangulation. And they discovered that he potentially interacted with 5,000 people. They ended up testing 2,700 who showed up for the testing, and then 168 were positive. So I do think that it is very reassuring that it's very, very rare. And I think, gradually, I guess on May 26th, I'm high-fiving everybody because I finally get to play tennis on the 26th. The golfers had a big jump on us. Swimming, baseball, softball opens on the 26th. You can go back to gyms. And I think that, we've been helping these places figure out ways to get back safely, but distancing, engineering controls, hygiene, limiting the number of people is all very important. UH is very proud that Dr. James Voos, the lead physician for the Cleveland Browns and our chair of orthopedics, is on the Governor's Sports Commission. And so, of course, all of you Buckeye fans out there and some Browns fans are wondering, are we going to get to play football? That's the big question. And we did hear that the NCAA said that June 1st, basketball players and football players are going to be able to get back to working out. And I know the Browns facility opens on June 1. We're on their website. We've been there almost every other day the past couple of weeks, getting them ready to open their training facility. And I think that, slowly we'll get back. Football is a difficult one because it requires very elaborate viral testing to be able to do that safely and with multiple tests, around and before games and everything like that. So football is one that maybe most of our audience isn't going to go out and play. We'll keep them to tennis and golf and a little bit of swimming. So Ted, maybe you have a question for Brett because I have a little pause here on some questions. So maybe why don't you fire one away at Brett? She looks like she's ready.
Yeah. So Brett, I think one of the things that I'd like for you to talk about, which was a great innovation for our patients, was the ability to monitor patients at home with the Masimo device. Mm-hmm. So do you want to share with the audience kind of the workflow that went around that and how that has helped us take care of patients even when they're not in the hospital?
Yeah, so Lauren Brister, our lead APP, myself worked closely with Dr. Ponevos' group to implement the Masimo Home Monitor, which monitors your vital signs, your oxygen level, your heart rate while you're at home. And where we started using it was in patients that would come into the COVID rule-out clinic, not just the ones with COVID, but any of the ones that were having shortness of breath, any changes in heart rate, any symptoms that they weren't feeling well. We would send them home with the Masimo monitoring device. The device is monitored by nurses, and then the nurses check in with the patient twice a day, and in addition, if there's any changes. And one of our patients, it did an amazing job. She was fine in the clinic. Her oxygen levels were okay. Within 24 hours, she got 2 phone calls. Her oxygen levels had dropped. They called her doctor, Dr. Silverman, and said, we're concerned, her levels are low. Where do you want us to send her back to the emergency room, to clinic? At the time, her levels were quite low, so we thought the safest place would be the emergency room. And she was subsequently admitted for blood clots in her lungs, pretty large blood clots in her lungs. And so we really picked that up due to the Masimo device and sending her home. So it's really done wonders for us, and it'll be something that we're hoping to continue to use in our cancer patients at home moving forward, even post this initial COVID pandemic.
So as a follow-up to that, Brett, what other innovations, if you will, have come out of this that you think will be part of our cancer practice in the future?
I think the other one which you mentioned earlier, which we sort of used briefly before but hadn't re-implemented, is the temp track. Another way to monitor patients' temperatures and to see if they have a fever. And I see that as really revolutionary in leukemia treatment and transplant, where patients stay in the hospital for weeks on end, really just monitoring for fevers, because we need to get them quickly back to the hospital if they get antibiotics because they're so immunocompromised. So we see this as a way to maybe get patients home earlier if we can still monitor them 24 hours a day to be able to get them back to the hospital quickly. So I would say both the Massimo and the temp track will be two things that will really change cancer care for our patients moving forward, and hopefully keep cancer care at home, which is our overall goal.
You know, Ted, Ted, you mentioned an amazing thing about sort of the silver linings of the COVID pandemic, and what have we learned, and how will that change care? And one of the things that, you know, we've talked about in the last couple of days, which is just really remarkable, and you did mention it earlier, is that somehow everybody has gotten together to communicate more effectively, even though we've been, for instance, limited in having family members. So by going out of the way to use iPads and engage the family with regular updates, the message to patients, what they're feeling and their families are feeling, is that we're actually communicating better. And there's no better example than your patient experience scores, which are breathtaking. They're in the 90th percentile now nationally, compared to all other hospitals in the Press Ganey database. I mean, to be in the 90th percentile as a cancer center is truly amazing, because you have very, very complex patients who are dealing with very complex hospitalizations. And it's not always a feel-good story, right? Some people get better and a lot of people don't. And to be in the 90th percentile it's hats off to you and your team, to Melissa and Brett and all the nurses and the doctors who are working there, because, you know, I've just been amazed. And we've seen that not only in the cancer center, which is leading the way in the 90th, but even Cleveland Medical Center overall now has domains in the 80th percentile for care transitions and discharge instructions. And we just, you know, we were not that good before. And somehow people are coming together. They're rallying around the need to be extra good now to be able to get this information across. The other thing that we've seen, which has been remarkable, is a reduction in the length of stays, a reduction in readmission rates, because people aren't going to skilled nursing facilities now. They're going home. They're going home with home care and the Massimo devices. Our readmission rates are you know, in heart failure, for example, one of my favorite things to look at, has gone from 18% in 30 days down to 5%. I mean, that puts us in the top 5% in the country. And so I hope that although we need to have this pandemic go away, I hope the things that we've learned about virtual, digital health, remote monitoring devices, communicating better, involving the family more effectively, will actually last after COVID goes away. I don't know if you've seen that as well, Ted or Brett.
I think the communication is huge. I think that what we've tried to do is that we try to set times every day with each patient and their family to say, we will call you every day at 10:30 to give you an update on your loved one. And that's different. So when patients' families were coming in, we would often miss them on rounds. We would round in the morning, they would be working, they'd come in later in the day, you might get a covering resident. We weren't doing that daily update or communication that we now are vigilantly trying to do each and every day at a set time. So multiple family members, if they want, can be involved in that communication. And I think that's something that we learn and definitely need to continue moving forward, are the expectations around communication.
Great.
The other part that I think is really another silver lining is, you know, the acceptance from both physicians and patients to do virtual visits. So, you know, we'd been talking for years about being able to do telehealth. And within a matter of 2 days, it was really remarkable. Nearly half of our patients were being seen in virtual visits. And Dan, you know better than anybody, we went from having a couple hundred visits to 4,500 visits a day using virtual health and telehealth platforms. Patients like it, and I think the physicians like it. So I think there's no doubt that that's going to become a permanent part of how we reach out to patients and how we do visits. As a surgeon, I can certainly see how post-operative visits can be done in this manner, and well checks can be done in this manner as well. So I think for as tough and as challenging as this has been for all of us, there's no doubt that there's going to be a lot of innovation that comes out of this, and that'll make healthcare better.
Yeah, I think the other thing that goes without saying, and we need to make sure that that we state this emphatically tonight, is we want to thank all of our friends and supporters for your generous outpouring of texts and emails and phone calls, and also some of your treasure. We've raised nearly $6 million for our COVID Caregiver Support Fund and our COVID Community Support Fund. The caregivers is being used for nutrition, we have special recovery zones in the hospital where they can go with counselors, get a fresh meal, a place to escape that's quiet. We've had terrific work from our expressive therapy groups and Counter Integrative Health with remote Zoom, continuous 24-hour concerts by the staff. It's really been amazing. And of course, the Community Support Fund is being used to support all these innovative clinical trials, which has just been fabulous. And I think the newest one that's coming, which is very, very important, is money that we've raised to do antibody testing with the new Abbott platform that has a sensitivity and specificity of over 95%, meaning that it's very, very accurate to detect prior infection. We're testing 10,000 healthcare workers and first responders, and we're starting that this week. And that's been supported and underwritten by many grateful patients. So we want to thank our friends and supporters for that. I know that you have funds that have been dedicated to Seidman cancer, and it's just, it's really, it's terrific.
Makes a huge difference. And some of it has also been used to underwrite a massive database for us to really look at how our patients have fared during this COVID pandemic time, and really begin to study how this pandemic has affected outcomes in cancer. So that all couldn't have been possible without the support from the community.
Yeah, I think Brett brought up a terrific point related to mammograms and colonoscopy and lung cancer screening. We know that every 1,000 mammograms are picking up a defined number of cancers. And I've heard statistics that, if you miss 10,000 mammograms, you could miss potentially 30 cancers. And we don't want to do that. And so we're working very, very hard to reschedule all those visits. Donna Pletch's group is working 7 days a week, 12 hours a day, making all these calls and getting there, and colonoscopies with John Dumont and the Digestive Health Institute. So this is really important. Brett, do you find in your own patients and in rounding that there's still a reticence to come to the hospital? I find myself still having to do a little negotiating, so to speak, to get them to come face to face. Are you seeing that in cancer? I mean, are you doing as best you can with virtual and digital? But clearly you must have times when you say, I got to see you face to face.
We do. So the virtual works really well with follow-ups. It works really well for survivorship. It works really well for anemia and benign hematology. In fact, that probably should be the choice visits for most of those visits moving forward. But of course, we need to see patients in person. And I was a bit surprised that there is a reluctance to come back even for cancer care. And so what we had seen is when we first started rescheduling, Troy Cordero and the PA staff were getting a lot of feedback that they would reschedule, but in July and August. And it was when we needed to reschedule in the next few weeks. So what we've done is, in addition to having the nurses call 2 days before, if it's someone that is reluctant to be rescheduled, we have both the nurse and the physician or APP team call the patient to sort of talk through their concerns. And then for all of the nursing phone calls, we are putting something in place to sort of talk through that Seidman is safe, it's COVID-free. We have all of these areas in place to keep things to keep you safe. So we're actually trying to make that part of our phone calls the 2 days before, and then even doing extra phone calls if that initial one doesn't work.
That's terrific. So Ted, anything else that's on your mind here? We have a few minutes to go. I want to make sure that we give you the final wrap-up word as the president and scientific director of Seidman. So the floor is all yours.
Thank you, Dan. I think, you know, the one comment that I want to make is that, you know, healthcare is challenging, as we all know. And then prior to this pandemic, one thing that was an epidemic in healthcare was caregiver burnout. So, you know, many of you have probably heard that, you know, as many as half of physicians were, you know, quote unquote, burned out, meaning that, you know, they were really emotionally exhausted in their work and felt disconnected a lot of times and cynical about healthcare. But, you know, one thing that this pandemic has done is it really has re-energized the healthcare workforce. You know, I think I can't remember a time in my career where everybody was so singularly focused and energized. And I think this is an opportunity. It's a real opportunity for us once this pandemic has passed, for us to really reimagine how we deliver care to our cancer patients. And also, it's been a real shot in the arm to healthcare workers. I think seeing all the support from the community, whether it be, you know, David Corey giving us 5,000 Subway sandwiches, or the Highlands bringing Girassi pizzas, you know, for everybody to eat. That support from the community can, you know, I can't even begin to tell you how important that has been in energizing our faculty and caregivers. So I'm very optimistic that once, you know, we are past this episode, that, you know, there'll be a new era and certainly much more enthusiasm, engagement, and really much better focus on patients and families than there had ever been in the past. And that's a good thing, certainly, for us all to look forward to when this is past us. And as I said, we are bringing an incredibly talented group of new caregivers into Seidman Cancer Center, and they're coming in at the time where, you know, we're really reimagining our future. So I think the future is very, very bright from both the patient perspective and from our research and academic perspective as well.
Well, that's terrific. I think we have to thank our terrific team, our technical team, because we've had no problems tonight, and that's not always happens on our Zoom calls. So thank you to Kelly, to Shannon, to Sheila, all the IR&D team in the background working on this. We thank you for everything that you do every day as well. I'll tell you, on behalf of the health system, we need the Seidman Cancer Center more than ever to care for our patients, but also to provide the lift that we need for the health system overall. And it's always so inspiring to see the care that you deliver to your patients. The quality, the team that you're assembling is just breathtaking. It's so great to walk over there and see Jordan Winter and see Marcos de Lima, and now Dr. Garcia, and our great radiation oncology team, and just everybody. Of course, we have the dynamic duo of Brett and Melissa, who are really driving amazing things there. So I want to thank all of you, Linda, Matt, your whole team is just tremendous. So thank you on behalf of all of us to you. Thanks everybody for coming this evening. Brett, you get the final word about physical distancing and masking, because you got your family down. So let's give our supporters and friends your pep talk that you give your girls.
Oh. No, I've made it into a fun thing. It's fun. It's just fun. Keeping you safe, fun, safety. Hand hygiene, sing the ABCs. That's what I'm leaving you with. If you want good hand hygiene, sing the ABCs. It will get you your full 20 seconds. I promise. Maybe 40 if you were my children.
Thank you so much. Have a great night, and we'll see you all soon live. Bye-bye.